Hi, I'm Dr. Dominic King. Today we're going to be talking about the post-procedure rehabilitation protocol for minimally invasive tenotomy applied to plantar fasciopathy and Achilles tendinopathy. So the rehab that goes into minimally invasive tenotomy after these foot and ankle procedures is important. I would say it's not more important than any other procedure, but you really have to pay attention to the fact that patients are walking around on the structures that you just did a procedure on. And so while we don't load them too quickly, it's very different than an elbow or a shoulder, where if it bothers them, they can use it a little bit less. They have some rest period. Patients are going to walk on these structures pretty quickly within the first 2 to 3 weeks. And that's likely why you may see patients come back a little bit more flared up at that 6 to 8 week mark. And you need to have a plan for how to address that. That plan begins with good preparation right at the start. So we break the rehabilitation up into 3 phases. This first phase is phase 1, so the protective phase. This is the first 14 days after the procedure. We are sending patients home from the procedure in a boot. It's either going to be a tall boot, tall cam walking boot for the Achilles tendon, or a short boot for the plantar fascia. If patients feel really comfortable on a knee scooter, they don't need to use crutches for the first week, but otherwise they're going to be on crutches, non-weight bearing for week 1. Crutches, partial weight bearing as pain allows. Week 2, they can do some general range of motion to gravity, do some calf pumps, decrease a little bit of DVT risk, but it really is a true protective phase. And we're not necessarily protecting them from tearing these structures, we're protecting them from overloading it. Remember that cross-sectional characterization of the tendon or the fascia, there are plenty of good fibers there, but intermixed with this large chronic degenerative tissue that doesn't allow those fibers to compress and load. When you remove that tendon tissue, you're allowing those healthy tendon fibers to reload. But when you're reloading those, you can overload them very quickly because they haven't been loaded like that in a long time. And that's why this phase 2 is the restorative phase. We're restoring that motion, we're restoring that load onto the tendon. So this is where patients are going to start into physical therapy, typically between the 14 to 28 days. Remember in previous videos, we talked about patients with significant hyperemia or longitudinal tears. They may be a little bit more flared up at this stage, so you might want to transition slowly into that 14 to 28 days. 2-to-1 ratio of eccentric to concentric exercises. When they start this, we want them to have kind of partial weight tandem exercises, so they're using the other foot to help if they're doing, a very significant Achilles type of stretch. But there is an importance of combining that eccentric to concentric. We're trying to reload those tendons. Remember, we removed the damaged degenerative tendon tissue, not the good healthy tissue, so we need to reload that. The high reps are important. High volume stimulates metabolic activity, but this is where you really want to have that good relationship with your physical therapist, so that if they're consistently painful, that maybe you want to order a musculoskeletal ultrasound to take a look and see if they're starting to get a recalcitrant tendonitis because they loaded it too much. We should be avoiding instrument-assisted soft tissue mobilization early on. Again, taking a tool and starting to get into the tendon too early is just going to cause more irritation than it's likely going to help. And remember, we remove that degenerative tendon tissue, so there's not a lot of tissue to start working on from an IASDM standpoint. Pain should remain below 3 to 4 out of 10. This is a nice rule for physical therapists to follow in terms of guidelines. And it's important for patients to know 0 is not what we're looking for. We're looking for you to be able to maintain 3 to 4. This is the healing process. And return to baseline after 24 hours. As long as we're not getting up into the 5s or 6s with therapy, we can continue to load this and continue to progress. So it is a very active restorative phase. And phase 3 is reloading. So we're in through the first month, we're getting into the second month of reloading with therapy. We're getting more repetitive type of activities, re-educating the load management. We're working on the glutes, the core. We're making sure that the entire kinetic chain is working together. We're expecting to return to work in repetitive uses by 6 weeks, again, depending on what it is that the patient is doing. We're expecting some initiation back to sports-specific type of activities by 8 weeks, and expecting them to have good progressive results within that 3 to 4 months. So if patients just ask right off the rip, how long is it going to be until I feel better from my plantar fasciopathy or my Achilles tendinopathy? We say, in general, most patients will say that the resolution of symptoms is coming around 3 to 4 months. Again, there's a lot of caveats to that, and that's why we're managing patients' expectations that if they have hyperemia, if there's longitudinal split tears, if it's an insertional Achilles tendinopathy, they can expect this to take maybe 5 or 6 months, but it normally takes them maybe 1 or 2 years to get into our offices. So as long as you set those expectations out at the onset, it's much easier to manage if anything comes back being a little bit flared up or we need to re-educate patients. From a pearl standpoint, that's why we see patients back at about 8 weeks. It's a great touch point 2 months in. Now they've gotten through those first 2 phases, they're starting to use the tendon. What I tell patients is at 8 weeks, most patients can say, I can definitely tell that something's better because of X, Y, or Z. It's the pain isn't coming on as significantly, or I don't really feel that sharp pain. I just feel that stiff kind of achy pain. It doesn't bother me as much in the morning when I walk on it, but by the end of the day, I still feel that soreness. Let them know this is completely normal. This is that time that they need to keep on listening to their body, not pushing through pain, but making sure to work with their therapist that they're not overloading, but they're appropriately loading. Managing those expectations is obviously important. Again, 4 to 6 weeks before they'll start to notice any significant results, 3 to 4 months before they forget about either their elbow discomfort or their plantar fascia discomfort or their Achilles discomfort, all of their tendon discomfort that they may have. We want to work closely with our physical therapy group, especially within those first 2 weeks of PT. So after that protective phase, getting into those first 2 weeks, we want to make sure that they're not meeting with a physical therapist who's looking at this as maybe a small dry needling procedure and they're going to overload it too quickly. You got to have a really close work with your PT group so they know if a patient's coming for an MIT or a TenJet follow-up, what that means and why it's okay to start loading them, but we need to make sure to manage their expectations. Consider that ultrasound, especially the power Doppler, if they're flared up at 8 weeks. We have seen people who've come back who've developed an Achilles tendonitis or plantar fasciitis because they overloaded it, and that's typically at 8 weeks. They always have some concerns of, did the procedure not go right, or did I tear this? And grabbing an ultrasound, tossing it on there and showing them, no, listen, the structure looks good, but I can tell you've been doing your exercises. It seems like you pushed this just a little bit too much, and now you've gotten a little bit of a tendonitis. Easy to manage at that time. If any of us who actually get to see that acute inflammation, not too difficult to manage either with ice, anti-inflammatories, a little bit of rest, kind of modifying some of their activities. I tend not to put people back into boots or immobilization. We kind of have this active, maybe a knee scooter or crutches with continued motion. And then probably the most important part, not only for you to understand, but to get across to the patient that the procedure needs to be treated with respect. You know, we said it before that patients are seeking you out because you have a new tool in the toolbox that can treat a condition that they've had that's been very chronic, that they've had all of the treatments that they read online, and then they find out that somebody does something that's new, it's less invasive, it's exciting. We treat this with respect. This isn't a microsurgery. It's a minimally invasive tenotomy. It is a surgical procedure. Just because the invasive is minimal does not mean that the follow-up and the importance is minimal. So we get that across to patients right at the start, that we will be able to get them back to what they want to do, back to what they love in a reasonable amount of time, but we always help to remind them with plantar fasciopathy and Achilles tendinopathy, these are conditions that take time to develop. They normally have been hurting or have some kind of discomfort for months, if not years. And so it's going to probably take that time to get back to functioning. But again, if you manage those expectations and set those expectations at the start, much easier for patients to know where they should be at 8 weeks, at 3 months, at 6 months. So hopefully this helps with some high-level pearls for the rehab portion of approaching minimally invasive tenotomy for the plantar fascia and the Achilles tendon. Thank you very much.